Welcome to TMC Fertility's eCME. Today's eCME will be about a GP's perspective. When should you refer your patient to a urologist? This session will be conducted by Dr. Muhilan Parameswaran. Dr. Muhilan is a consultant urologist, former lecturer, and currently Dr. Muhilan is practicing urology at Thomson Hospital, Kota Damansara, and also TMC Fertility Puchong. So if you guys have any questions for Dr. Muhilan throughout the session, please feel free to just put it in the chat box, or you can just, directly WhatsApp your question to Lisa and we will convey the question to Dr. Muhilan later on. All right, and without further ado, Dr. Muhilan.
Hi, good afternoon. My talk today is basically about very simple thing. It's about the cases that GP sees and that I see as a urologist. So we both see certain things in common and we're going to discuss those. So but the way I see it and the way you guys see it may be slightly different. So we're going to correlate the two things. And among the things we're going to discuss is what for patients with blood in the urine, patients with loin to groin pain, patients with recurrent infection, and patients with testicular pain. So 4 basic symptoms. My slides are very, very few. They're only about 9 slides. And it's not complex. It's basically my view of what I see from the same symptoms and your perspective of the same symptoms and how we put it together, right? So let's start with the first slide. So let's start with something that's very, very common, causes a lot of confusion. Someone comes to you and says, look, I got back pain. Commonest thing, I've got abdominal pain. And the pain goes from somewhere his back and it goes down all the way down to his testicles or his groin or her groin. One is difficult. You could be back pain, it could be stomach pain, you could have colic, you could have kidney pain. Most of the time you guys will do, or I would do the same as you guys, and we would all do a simple urine check. We look for blood in the urine. We do a quick ultrasound, make sure the kidneys are swollen or not, and we rule out that it's a back pain or tummy pain. Now, we don't need a referral for all these cases. If you check the patient and you convince and you can see the stone, it's a very small stone. A trial of conservative treatment, a lot of people like Cystone or Rovatinex with painkillers would be sufficient. Now, when is it that it moves away from being treated as an outpatient basis to someone requiring inpatient treatment? If the same patient comes back within the next 2 days and he's in agony, he's like screaming, severe pain, admission for pain management is warranted. If this patient comes and says, look, I've been having fever, chills and rigors last 2 days, you check his tummy, it looks like he's got pyelonephritis or he's got huge amounts of blood coming out from his urine, referral for inpatient management is probably warranted. Now, based on what is available, you may want to repeat your ultrasound, confirm that it is a pyelonephritis with hydronephrosis, or you can confirm with an X-ray KUB, but please be aware that a good chunk of stones can't be seen on X-ray KUB. But here's the thing, if a patient starts developing complications of stone or the stones are large, this is a good time to send the patient. And on a general note, any patient with severe back pain who's not responding to painkillers, who's not responding to conservative treatment would probably be better managed as an inpatient. So that's symptom number 1, pain. Right? So this is the simplest, commonest thing that a lot of us see. Let's go to the second one, blood in the urine. If you read the books don't differentiate whether it's microscopic or macroscopic, and theoretically it should not make a difference. But realistically, anyone with fresh blood probably has a more serious problem than anyone with microscopic hematuria. Now, as I tell everybody, pain in this case is a good thing. Pain means it's infection, it's inflammation. Those not so scary as the painless hematuria. So the first question, anyone who sees blood in the urine, if you have pain, if I'm in a clinic, outpatient clinic, I would probably first do like what most of us do, which is we check the urine, make sure it's infection. If it's not infection, you suspect a stone, fine. Then it goes back to step 1, where you treat it as a stone. Again, if you suspect infection or you suspect stone, 3 to 5 days of conservative management with painkillers, antibiotics to let everything resolve is not a bad thing. When does painful hematuria require admission or require inpatient management? If you require more invasive or more extensive investigation, that means if you are worried that instead of a stone passing out, this could be a blood clot from a kidney cancer, you want imaging, you want CT scan, please refer the patient. If the symptoms are not resolving, okay, so this patient has agonizing, painful, gross hematuria, 3 days of antibiotics, painkillers is still not settling, he will need a CT scan, and if the CT scan is normal, it probably needs a scope as well. right? So what am I worried about? I'm worried about a stone with complications, a stone causing hydronephrosis, a stone stuck in the urethra, which is agonizingly painful. So if someone has painful hematuria, burning urine, and now your symptoms are getting worse, that means you see them presenting with symptoms of renal infection, pyelonephritis, or abscess, please refer the patient. But until that point, a course of antibiotics, pain management, as long as you keep an eye on them, is fine. Let's manage it as outpatient. Third one, the cases get more interesting as we go along. Right, so this is the bad one. Patient comes, you have microscopic hematuria persistent, you have gross hematuria persistent. Anyone with gross hematuria who is painless, you need to come to a diagnosis within 2 weeks. That is, by hook, by crook, you do need to rule out everything within 2 weeks. Okay, that's your time frame. So you need you need imaging, good imaging, CT scan or contrasted CT scan to make sure you don't have an upper tract tumor. That's your kidney or your ureter. I prefer CT with contrast unless the kidney is damaged. Then if the CT scan is normal, you proceed to a bladder. Now, if you look on your right-hand side, you'll see two images there. I hope they're clear. This patient actually was a relative of mine. He came in as an 80-year-old man, very fit, and he had prostate problems. So he kept complaining of hematuria, and I didn't follow my own rule. Sadly, I didn't settle it within 2 weeks because a relative, I didn't want to do too much. So I thought it's bleeding from an enlarged prostate because he had a huge prostate. So I sat on it, and finally, okay, let's put in a scope. And that was what I found. That's an aggressive TCC. That's a bladder cancer. And this patient, which was incidentally my relative, had his bladder removed because that cancer had infiltrated all the way out. So painless hematuria, we have 2 weeks to investigate and come to diagnosis. Now, for all these patients, the reason for referral is two parts. One, to confirm your diagnosis. Two, to manage a complicated diagnosis, something that you don't want to manage as outpatient. So for example, you want imaging to confirm whether it's a stone, whether it's a complicated infection. Management as inpatient, either IV antibiotics, surgery to solve the infection, to put in a stent, remove the stone, whatever it is. So referral is for two things: to get a diagnosis and make sure there's nothing sinister. Two, for further more extensive treatments, right? So we covered back pain, we covered the two hematuria, painful and painless. Okay, this one's interesting. Now, almost every doctor I know treats urinary tract infection. If you will divide the patient into young, old, male and female, right? Someone comes with UTI, sexually active young woman, right? They are very prone to urinary tract infections. Likely there's nothing, right? So I would tolerate 2 or 3 infections recurrent within a year for young woman who's sexually active. And probably the treatment is recurrent use of antibiotics, sufficient as long as we do urine cultures and make sure there's no blood in the urine. Now, if the patient is a male, especially older males, people who are not sexually active, or even young women who are sexually active but are getting very frequent urinary tract infections, you need to ask why. Why is this woman getting urinary tract infections? Please don't jump to the conclusion it's an STD. From experience, I'll tell you 95% plus are not STDs, right? They're common bugs, they're Klebsiella, Pseudomonas, E. coli, and they seem to be recurrent. Now, these people need investigation. What am I thinking? What am I worried about? In younger people, I'm worried that either there's the infection for women almost always is vaginal. That means it's from the vagina to the bladder, bladder to the kidney. Are we missing a vaginal infection? Are we missing a recurrent vaginal infection? Are we missing a fungal infection? So obviously that needs to be investigated. Is there something wrong with the bladder? Is there a bladder outlet obstruction? Is there something stopping this woman from passing out all the urine? So a simple scope will answer that question, or a vaginal exam. That means you ask her to pee, check residual urine, would also solve your problem. Now, the problem comes with older women and older men above 45. If you're feeling very paranoid, it's 40, but 45 is fine. So at which point, if you have a 45-year-old woman who's getting recurrent infection, you need to start thinking, does this woman have a stone causing recurrent infection? Very common. They get triple phosphate stones in the kidney, and you get triple phosphate stones are layers of bacteria and calcium. so they get recurrent infection? Is this woman having an underlying diabetes that we are missing? Or does she have some form of urethral obstruction? Possible she's delivered 3 or 4 kids. She's got prolapse, something that would obstruct the flow of urine. That's for women. For men, you would worry about prostate problems. Does this guy have an enlarged prostate? Does he have a urethral stricture? Does he have bladder cancer? So basically, when you have recurrent or persistent UTI, the reason for referral is to find out the why. Why is this person having recurrent infection? And that why is basically a series of diagnostic tests. The commonest one is cystoscopies. So my practice is I do get a lot of referrals for this. So what we do is we admit them. We do, if you want to claim insurance, you've got to get admitted, no choice. You get admitted, you do a cystoscopy, you do a biopsy of the wall, you do a vaginal swab, vaginal exam. If they've not had a pap smear, we get that done as well. And usually we'll find something, some underlying reason why they're having recurrent infection. Once we have it, we treat the infection, we do the appropriate counseling, and usually a lot of them will require long-term follow-up. So that is usually outside my scope. So that's the part we send it back to you with the results of the investigation, and that will help you treat this patient in the future. So that means your complex cultures, your scope findings, CT finding, and vaginal findings. So the reason for referral for recurrent or persistent UTI is more diagnostic to find out why he, she, or nowadays is transgender as well, has recurrent infection. Right? Recurrent infection. Let's move on to the next one. Lower urinary tract symptoms. This one's iffy. Now, anyone who's been practicing medicine, you're going to see this, right? You're going to see patients come in and tell you long list of symptoms, right? They get up to pee at night. They run to the bathroom. When they want to start to pee, they have to wait. That means the pee doesn't flow out straight away. They have to wait. And when they're finished, it's incomplete, right? So lower urinary tract symptoms, we divide it into 2. Those linked to the bladder, those linked to the bladder outlet. That means your bladder neck, the urethra, the prostate. So what are bladder symptoms? Bladder symptoms is those linked to irritation. So getting up at night, running to the bathroom, going often in the daytime. These are bladder symptoms. Prostate symptoms, bladder outlet symptoms, poor flow, difficulty starting to pass urine, and when you finish passing urine, there's urine left behind. Now, the misleading thing about this is a lot of people, these symptoms develop very, very, very slowly. So they get used to it. So every day, swear to you, it is every day, someone walks in and says, I have 0 urinary symptoms, my urination is fine. And then when you ask what they mean by fine is, they're getting up 3 times a night is fine. Getting up 5 times a night is fine. Running up the bathroom is fine. People learn to adapt to the symptoms. So please go through the symptoms in detail, and you'll find out that a lot of people who come with infection or distended bladder or difficulty, they strain to pass urine, they will have a long history. Why would you want to refer in this case? After all, it's fairly easy, right? You give alpha blockers or overactive bladder medication. Again, diagnostics. You want to know why. When someone comes and tells you they have one of these problems, you want to know why. Once you have the why, then the treatment is fairly simple. It's medication, which they can do as outpatient. That's fine. Or it may be surgery for those not responding to medication. So let's go down some common differentials. Young women. Young women is going to be infection, common one infection. Lately, I've been seeing a lot of drug use, okay? Especially there's this wonderful street drug that provides a lot of irritation to bladder. I shouldn't say wonderful, I should say bad street drug called Ketamine. I'm not sure whether you all have heard it. It's very, very popular in a lot of underground pumps. It's called Ketamine. It wipes out the bladder. So you get young patients, male and female, who come with symptoms of urinary tract infection. There is nothing on the urine. You put in a scope, you'll find it's contracted, tightened bladder. Number 1. They pee every 15 minutes. They have to run to the bathroom. So infection, drug-induced cystitis, young patients. Older patient, above 40, again, you're worried about cancers. Bladder cancer can cause all lower urinary tract symptoms. And bladder cancers can also cause recurrent urinary tract infections. They also can cause recurrent hematuria. That's the bad one. Males, prostate. If there are enough guys here, welcome to the club. To be fair to God has decided guys need something, so we got prostates. Our prostates grow slowly. We start feeling it about 45. and you'll have mild symptoms. So that's a very common thing. All of us have prostate enlargement. It's whether you're symptomatic or not. 20% of us within the prostate, you will have a cancer, right? The commonest male cancer. So that's the blood test. So again, when you have lower urinary tract symptoms, treat as you see fit, depending on what your diagnosis is. But if it's not resolving or it's persistent, we need a diagnosis. And this is where I come in. I help you guys get a diagnosis. So if you notice the common trend throughout most of the symptoms, my role as the inpatient care provider is that I help you all come to a diagnosis, but long-term care is usually back to their family doctors or GP or whoever their panel covers. But my role, where I'm going to help you guys with, is helping you all to come to a diagnosis, right? And for cancers and stones to treat. Okay, testicular pain and lump. Now, this one's interesting. This is a very guy thing. Let's divide patients into three. You got the very young, you got those very, very young guys, right? So these are your 20s, right? Below 20. Then you got the 20 to 40s, and you got the 45 and above. The below 20, so those are your kids, your grandkids. Those are very young. So these young boys, if a young boy comes and tells me, I wasn't doing anything, I was just sitting down, and suddenly my testis hurts or my balls hurt. If the pain is severe, that means it's painful enough for him to come and tell you. Let's assume, until proven otherwise, that it is a torsion. Torsion cannot be managed outpatient, and torsion needs an urgent referral, right? So they come to the hospital, they do a Doppler. If the Doppler is negative and I'm still feeling suspicious, I will operate. Okay, because it is better to operate and be wrong that it is not a torsion than to miss it and to lose the testis, right? So any young boy, 20 years old, comes in, I worry about torsion below 20. Now, if he comes in and there's signs of inflammation, the skin is inflamed, the testis is still mobile, the crumastoid reflex is present, that means you have more towards inflammation. Urine FME is positive, and your Doppler ultrasound is normal. Treatment is antibiotics. But suspected torsion is one of those where I would not try treating this as outpatient. I would do it urgently as possible to a hospital, get an ultrasound Doppler, and seriously, I try to get them into theater within 6 hours. Okay, that's your 20s. 20 to 40. In 20 to 40, again, a painless lump, and it's a testicular lump, right? So if the lump is on a testis, that means you examine the testis and it's the testis that's swollen, not the epididymis, the testis. 20 to 40 is cancer, right? Until proven otherwise. The commonest cancer in young men is testicular cancer. Again, both diagnosis and treatment is inpatient. You need a very good ultrasound of the testis. And if you see cancer, you do your tumor markers and you, right. Older guys, sexually active guys who are naughty, right, who mess around. Older guys. So let's say someone comes, you have a gentleman, 55 years old, 60 years old, right? And he comes and says, look, I keep getting this testicular infection. And you examine him, it looks like infection, right? Classic, tender, skin is inflamed, epididymis is swollen. So your diagnosis is epididymal orchitis, right? Okay, but you go through a history, he's a good boy. Doesn't have sex, or maybe only has sex with his wife, whatever it is, but no reason to suspect STD. Now, here's the thing. Enlarged prostates, bladder outlet obstructions, also cause recurrent orchitis in males. In males who are younger, who are sexually active, it could be STD or it could be a bladder outlet obstruction causing recurrent testicular pain. So I had this gentleman who's a polio patient, not very old. He's about my age, 50. Yeah, I'm about 50. He's about 50. He's a good boy. He does not mess around. Okay, only has sex with his wife. He's a very good boy. That's good. That's a good thing. So, but he's been treated for recurrent UTI, recurrent orchitis for about 8 months. And the last time he went, he was offered excision of the epididymis because there's a part that gets recurrent obstruction. So what I did was I just did a flow rate. His urine was poor. The flow of urine was very poor. Put him on an alpha blocker. I like Hanal or Cadura or Zatral, pick one, but I chose Hanal for this guy. And his urine started to flow better. And the testis resolved. So testicular pain and lump is a bit different. If it's in a young patient, it should be managed only as inpatient, because the faster we get a torsion into surgery, the better is the outcome. I wouldn't even do diagnosis. I wouldn't do anything as outpatient. I would refer this case, get a Doppler done as soon as possible in a hospital, and we operate. Young boys, you have a bit longer time frame, but again, cancer will be your number one diagnosis and treatment is surgical. Older guys, my role is to help in finding out why they are getting testicular infection or testicular swelling. Now, not as common. I see maybe one out of every 100 testicular swellings above the age of 50, and I get this diagnosis. So you get this enlarged testis, very smooth, very homogeneous, very big. And you think like, hey, this guy is 50, right? His risk of testicular cancer is almost zero, and it's not painful. Okay, above 50, you don't get testicular cancers that are present in a lump, you get lymphomas. So blood cancers, one common diagnosis is testicular swelling. So you get this big testis in gentlemen above 50, no pain, homogeneous, smooth, persistent, and if you do a scan, it looks very smooth. And if you check through the bloods and you check through the lymph nodes, you'll find a lymphoma. Again, my job is find it, remove it, and send the patient for chemo. All right. So again, to reiterate, my role here is to support you guys in helping you guys to come to a diagnosis. A lot of this can be treated as outpatient. That's the medical part. The surgical part, we do it as inpatient. If you are worried about a diagnosis, if you're worried about further treatment, that's why we help you. But once you have a diagnosis, most of these patients can be treated as outpatient, right? That is the last slide. So as I promised you guys, this is a very short presentation. Again, just to reiterate, right? A lot of things is diagnostic in nature. And a lot of it is sometimes you need an opinion, all right? So you don't have to refer everything. Sometimes it's just easier, just pick up the phone or drop me an email or send me a WhatsApp and just discuss the case with me. So most of the time, I can help you all find a diagnosis without actually sending the patient to the hospital. If I think it needs to be seen in the hospital, I will tell you, but a lot of my friends just call me just to discuss things. It's fine. We're all colleagues. And honestly, with COVID, it's often easier for the patients to be treated at their family doctor, right? Okay, so I've given you guys my phone number. I've given you guys my email. And for the more high-tech guys out there, if you scan that QR code, that's my information. It has my nurse's email, my clinic email, and everything. I'm open to questions. Shall we start?
All right. So thank you, Dr. Muhilan, for the informative session. We do have a few questions in the chat. So I would like to remind the doctors, if you have any more questions, if you have questions, right, you can just put it in the chat or you can send it to us via WhatsApp. The first question, Dr. Muhilan, we have
Andrew, 1 second. All right. Now,
yes,
I realize I might not be able to cover all your questions, and there may be follow-up questions. So if you all notice my handphone number, and that is my handphone number, I only have one. If you send me a WhatsApp, right, tell me who you are, that you're Dr. So-and-so, I will do my best to reply. It may take me a little while, but I reply. So if you want to discuss a case, just put the case up. You don't have to mention patient's name. We'll keep it confidential. And I'll give you my honest opinion, right? So we'll try to do as much as we can from your clinics, right, at this COVID time, and we'll work from there. So I realize I cannot answer everything, but my number is there. If you need, please just WhatsApp me, right? And I'll try to reply as fast as I can. Right, Andrew, let's get to it.
All right. If a patient has been worked out for a uro referral, is confirmed to have renal parenchymal disease based on USG, KUB with underlying long history of poorly controlled DM or HPT. Does it still warrant for a urologist referral?
No, sadly, no. All right. Okay, so if you have, so this patient is a CKD, right? It's chronic kidney disease. I do get referrals for CKD is for me to find out if there's anything I can fix. So let's say same patient had renal stones. Yes. Patient has bladder outlet obstruction. Yes. But the case you're describing, honestly, a good physician would probably be better since it's poorly controlled diabetes, hypertension, or if you are comfortable managing it yourself, yes, no, don't refer.
Okay, the follow-up question to that is, if the patient has been referred to urologist for more than 2 years previously for hematuria and was diagnosed due to the renal parenchymal disease, is it a repeat assessment to urologist necessary for the same?
Not for 5 years. Okay. So if the patient had come with hematuria, I would have done a CT, or in this case, in CKD, I would have done a plain CT scan and a scope. The scope is valid for 5 years, right? That means even if a cancer started growing the day after the scope, it'll take me 5 years to see it. So this patient will have persistent hematuria, re-evaluation 5 years, roughly.
Then the next question we move on is, can you tell us a little bit more about Nocturia?
Okay, so Nocturia, two things, right? So basically, if anyone gets up more than once a night to pass urine, within an 8-hour sleep cycle, you consider it abnormal. First step, differentiate, is it the patient is getting up because he wants to pee or because he's got insomnia and is running up to the bathroom because, in general, he can't sleep. Number two, look at the patient's volume, water intake. I have a patient who took 3.5 liters of water before bed. I would pee many times if I drank 3.5 liters before bed. So water intake. Common reasons: polycontrolled diabetes, again, simple. Age, diabetes insipidus, where patients pass more than a third of urine during the night. Normal adults only pass 30% at night. We pass 70% a day. But as we age, the clock goes haywire and you tend to pass equal amounts. So if I was to diagnose nocturia, the patient has to be either passing small amounts of urine very frequently at night. So if someone's passing small amounts of urine many times at night, there's a problem. Small amount means 150, 200 mils, very often. Either you're not emptying your bladder properly or there's something irritating your bladder. Not emptying your bladder properly, prostate problems. Irritating the bladder, infection, cancer, stone, right? What would I do? I would first make sure it's not a diabetic, simplest thing. It's not a urinary tract infection. A warning about urine FME. When patients come to your clinic, you tell them, give you a urine sample, they'll go drink 2 liters of water and give you this urine sample that looks clean. So as a rule of thumb, I ask them to bring the urine from the morning sample, to grow a culture and do urine. Check for infection. No infection, their volume of intake is normal. I would ask them to come to the clinic, pee, see if they empty their bladder completely. If they empty their bladder completely, consider a scope. If they don't empty their bladder completely, look at the age, male, female, above 50, below 50, and consider treating for bladder outlet obstruction. Okay?
Right. We move on to the next question.
Right.
79-year-old patient having varicose vein on one side of the testicle. What can be done?
Right. Leave him alone. Seriously, leave him alone. I mean, varicocele is painless, right? It is painless, right? Most of the time, unless it's very large, then you get this dragging sensation. If it's 79, please do an ultrasound, especially on the left, look at the kidney. If the kidney is normal and this patient is asymptomatic, leave it alone. If it's very bad varicocele, you can do embolization. I would do embolization, but it's a bit expensive. Or I'll just ligate it. It's a daycare surgery, ligate the varicocele, not a big deal. But honestly, 79-year-old, I don't bother. Varicocele is more important for infertile couples.
Okay.
All right. Not everything needs to be treated. Okay.
The next question is, should I be alarmed if a lady asymptomatic, not menstruating, but has blood 1+ on routine urine FEME on medical checkup?
Yes. Okay. So here's the thing. Don't forget, right? When you guys do, or when we do urine FME, right? For not menstruating female who's got blood in the urine, I would do a pap smear. I've seen CA cervix with intermenstrual bleed who don't realize it and they show blood in the urine. If she's young, I want to make sure she doesn't have chronic cystitis. Okay, number one. If she's older, above 40, I want to make sure she doesn't have a small cancer sitting around the bladder or the kidney. So a once in 5 years scan. If you are worried about radiation, an ultrasound KUB and a pap smear, a vaginal exam would be mandatory for this woman. So if you don't have to be alarmed, but she does require investigation. Chances are, if she's young, below 40, 90+% you're going to come back normal. But unfortunately, there is that 10% who you're going to find something. And please don't forget, CA cervix is a disease seen in 35-year-old women, 35 to 45-year-old women, and a lot of them come with urinary problems.
Okay.
So please check. Yeah, definitely.
All right. So
cool.
Does KUB X-ray still has a role in a GP setting?
A good KUB, it does, right? So don't forget, KUB shows you a lot of stuff. So you would have done a KUB because patient has abdominal pain with, say, some blood in the urine. The KUB is going to show you a radio opaque stone. Anything above, it has to be about 0.5 to 1 cm to see it. But that's about 70% of symptomatic stones. So you pick up 70%. In some situations, depending how good your KUB is, you can also get a rough image of the kidney, and you can see the kidney look enlarged. And you can also see the intestine and make sure it's not constipated. Patient may have severe constipation causing abdominal pain. So as a screening test, KUB is good, and honestly, it's the simplest, fastest thing that is objective that we can do. Of course, ultrasound is a skill, all right? I have a couple of my colleagues, especially a colleague of mine who sends me patients from Subang. His ultrasound skill is amazing, but not everybody has good ultrasound skills. Well, X-ray KUB is simple. All of us basically can read an X-ray KUB, right? But ultrasound has superseded KUB in a lot of things, but it's a skill, and it depends on your level of training, right? So if you don't have the skills for the ultrasound, X-ray KUB works wonderfully, but if you do, ultrasound is much better. All right.
The next question is, any use of Minerin in the treatment of Nocturia?
Okay, I don't like Minerin. I really don't like Minerin for various reasons. Okay, so what Minerin doesn't solve the problem, right? Minerin is symptomatic treatment. So what Minerin does is it stops your kidney from producing urine. That's all it does. It doesn't actually solve the nocturia. You actually have not investigated and found out why this patient is passing urine at night. So Minerin is indicated in patients confirmed who have SIADH, inappropriate antidiuretic hormone secretion, which is seen in elderly. So you need your bloods, your urine to confirm it. So these patients produce urine excessively at night. For them, Minerin works. In clinical practice, they make up less than 5% of patients. Now, in other 95%, instead of finding out why the bladder is behaving badly, all you're doing is shutting off the flow of urine into the bladder, right? So you're reducing urine production. Now, what happens? You are diluting the flow, the blood in the circulation. So a lot of these patients will have low sodium. So if you check their sodium samples 1 month, 2 months, please check if you're using Minerin. You will find a lot of them have low sodium. When they have low sodium, they will become confused and they'll pee even more. So Minerin is a good drug for SIDH. Outside of SIDH, I do not use it for nocturia. Okay, because I believe if you're going to treat something, we should know why we are treating it or what's the diagnosis. We shouldn't treat the symptoms alone. And honestly, if you got nocturia, it's not very difficult to treat. I would just do a 2-day, ask the patient to keep a record of what he drinks for 2 or 3 days at night before bed and his total intake per day. And then for males, I'll usually try an alpha blocker first. Make sure his PSA is normal. Start an alpha blocker. That solves a bit of your issues. And if he's still got nocturia, you do a scope, make sure there's no cancer, and then start medication for overactive bladder, right? Much easier, much safer.
The following question is, do males get pelvic congestion syndrome?
Okay, that's a good one because, okay, I'm going to be honest here. I'm not God and I have no idea what that is. Okay, I don't know what is pelvic congestion syndrome. Okay, I'm admitting my ignorance here. So
okay, Ken. So we have another question. It's how do you know that the patient has completely voided urine?
Okay, that's easy. I think almost everyone has ultrasound machine, right? So the normal ultrasound machine, right? Ask the patient to pee, put the ultrasound probe. And if you adult male should have less than 100 mils, if you're above 50, I would accept up to about 100. For women, less than 50, right? And they've voided their bladder. Simplest way, just do an ultrasound machine. There's some companies who send this handheld probe. It costs about, I bought one a few years ago for about 20,000. You can use it, but honestly, I think an ultrasound probe is best.
All right. So this question, 80-year-old patient, hematuria 1+ for 20 years, cystoscopy done 10 years ago, normal findings, urine result is the same for years. Diabetic well controlled, uterine prolapse was treated 10 years ago. Should she still be investigated further?
You know, she's 80 years old, right? Let's be practical a little bit here. Okay, this is not strictly speaking, this thing is a more practical part. If she's an incredibly good 80 years old, I will start off just, you know, all doctors can refer patients for CT scan. You don't have to refer to me, you can refer for CT. Just get a plain CT scan, right? Make sure there's no stone disturbing her or anything simple. If your plain CT scan is roughly normal and she's asymptomatic, she's 80 years old, leave her alone. If your plain CT scan shows a malignancy or suspicion, you do a contrast CT and then you decide what to do. But if you have a bad 80-year-old, that means a very frail, very elderly, and I know this is going to sound bad, someone with poor life expectancy, say they are 2 years or 1 year life expectancy, let's be practical and leave them alone. If they're asymptomatic, leave them alone.
Okay, and the last question, is it a correct practice if we diagnose a patient with AUR secondary to BPH to discharge the patient with CBD, give alpha blocker and trial of removal the CBD within 2 weeks? Or is there any better management for the patient?
That's actually textbook, right? That's textbook. That is perfect. That's the correct medication. There are modifications to that, but that is perfect. That's correct. What is the modification is, please, I would do a couple extra steps. I would check for constipation, because males with large prostates, if you're constipated, we can't pass urine. So I would make sure they're not constipated. I would give some lactulose. I would check for urine infection, because if they had retention for a day or so, they may have urine infection. So short course antibiotics to go together with it. Choice of alpha blocker. Yeah, that's fine. That's perfect. I mean, that's textbook. Whoever gave you that was doing it perfectly. I can't work better than that. That's perfect.
Okay, thank you.
Please remember to do a PSA 1 month later after removing the CBD, right? Not while on CBD. After you've taken off the CBD, 1 month later, do a PSA, right? Make sure it's not a cancer.
Okay, so Dr. Chua has came back with the clarification. Pelvic congestion syndrome presents with pelvic pain. It is due to poor pelvic venous drainage, especially on the left because it drains into the left renal vein. Less so on the right because it drains into the IVC.
Okay, so honestly, this is the first I'm hearing of it. I do not know this. We have something like that in males. That's why if you go back one step, I said the patient, the varicocele, you do an ultrasound on the left kidney. The left renal tumors can present the left varicocele, but pelvic congestion, I have to go read up. Okay, I really don't know. I need to go read this up, right?
All right. So sorry for that, Dr. Chua. Then perhaps you can contact Dr. Muhilan directly. Then you guys can, of course, discuss this further lah. Yeah, this topic. Yes, and I'm sorry, I did say that there is it was already the last question. Another three more questions. 60-year-old male with enlarged prostate, asymptomatic and normal PSA reading. Do we need to investigate further for prostate cancer? Any treatment options available?
Okay, right. So 60-year-old normal PSA. Just keep, okay, so normal PSA, let's follow the European standard, is 4. Repeat his PSA every year. Go by symptoms. If the gentleman is fine, he's happy how he is, leave him alone, do a PSA every year, right? If the PSA is very, very low, 0.5 or 1, you can do a PSA every 2 years. But no, that's it. I would just watch. Okay?
All right. And next question. 62-year-old male with prostatism SX shows thickened bladder wall and prostatomegaly, given alphatron ER, but cause dizziness. Anything better?
Right. So if he's got thickened bladder wall, basically he's a chronic bladder outlet obstruction. So he must be on treatment. If not, you're going to have a lot of problems, right? Okay. If he's got giddiness, you can change category of drug, right? So you can either give him a 5-ARI. That's your finasteride, which is available as generics. It's very cheap. You got dutasteride, which is the same 5-ARI. So they will shrink your prostate by 30%. But problem is they take 6 months. So that's your long-term plan. You also can use saw palmetto or pumpkin seeds in a 6-month period. For immediate relief, a good alpha blocker that has less, all alpha blockers have the same symptom relief, right? There's no difference. It's just the side effects. You can try Hanal, alfuzosin, 0.4 milligrams would probably work. If they are still sensitive to Hanal, you could try Cialis 5, which is a PDE5 inhibitor. That's your Viagra, 5 mg per day. It's sold for prostate dose. It does not cause giddiness, but it's very painful to the wallet. It costs about, I think in private practice, it's about $250 to $300 a month. No giddiness, works well, and on the plus point, you probably have a good erection as well.
All right, thank you for the insight. Okay, this one is the last question. What percentage does CA prostate have a negative PSA?
Right, so that's an interesting question. That means what they're saying is your PSA is normal, less than 4, and the patients have CA prostate. Okay, most of this data comes from Western countries, right? Europe or the US, where 20% of people have prostate cancer. So for them, it's about 3 to 5%. 5%. Now, Asians, it's very interesting. Asians have a higher incidence of high PSA with no cancer. Don't ask me why that is, but it is. The study was done in UM. I know we did it. I know UM did it, and I was part of that group that did it. So we had this huge group of people with very high PSAs, no cancer, all Asian. So in Asia, the numbers are probably less than 5%. But I'm guessing because there's no data. But the data that you see from European and American countries, that means about 3 to 5% of prostate cancer patients have normal PSAs. Now, what happens here is if you're worried, you can do a free and total PSA, which will tell you whether a biopsy is warranted. MRI, free total PSA, digital exam. All of them just tell you yes, possible, no. It is not, none of them are diagnostic. End of the day, if for some reason you are worried this patient has prostate cancer, even at a low PSA, do a biopsy or arrange a biopsy. Okay?
All right. So that I think that's the end of the long list of questions that we have, Dr. Muhilan.
That was fun though.
Yeah, on behalf of TMC Fertility, I would like to say thank you for spending your Saturday afternoon here with us today. And of course, for all our guests and your fellow colleagues here today, I would like to say again, thank you very much for joining us. So we do have CMEs every single month. You can get Lisa to send you the tentative dates if you require. And yeah, thank you for joining us again. Thank you guys for spending your time with us here today on this lovely Saturday evening. I hope you guys enjoy the rest of your weekends. And Dr. Muhilan, thank you. And I think this is goodbye. So you guys have any questions, you can contact me or Lisa directly for Dr. Muhilan's contact number. So you can discuss any questions that you may have with him on a more detailed basis.
All right. Goodbye, everyone.
Thank you, everyone.
Have a nice weekend.